Hi everyone, and welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute.
Or plain?
Right, or plain coffee break, or whatever your curiosity calls. I'm Haque, your host for today's episode, and with me is...
Shaimaa Jamiel. And let's set the record straight before we begin. Yes, I love medical podcasts, but I also have an unhealthy obsession with plane crash investigations.
which frankly terrifies us all. But listen, the good news is if Shaimaa can enjoy learning what causes a flight to go wrong, you can definitely enjoy learning how your metabolism stays right. And honestly, understanding vitamins is kind of like an accident investigation too.
Wait, I love that analogy. How so?
If you think about it, vitamins are like small, easily overlooked pieces in an aircraft. They sit quietly in the background, invisible most of the time, until one of the tiny pieces falls apart. And when it does, everything spirals. Structures collapse and systems malfunction, and suddenly nothing works the way it's supposed to.
That's perfect. And the best part is that you, the listener, can learn how to prevent these metabolic crashes long before they happen.
So buckle up your metaphorical seatbelts, put your tray tables up, and get ready. Today's journey will take us through the world of vitamins A, B, C, D, E, and K, what they do, how they work, what happens when you have too little or too much, and what happens when your body depends on them more than you realize. Before we zoom into individual vitamins, it's helpful to understand the landscape as a whole. Shaimaa, I know everyone has heard the term micronutrient, but what does that actually mean for our bodies?
It means they are organic compounds our bodies need in tiny amounts, hence micro, but their impact is enormous. They're called micronutrients because even though the quantities are small, their absence leads to profound classic deficiency diseases. They can also cause toxicities if they're in larger amounts.
Exactly, and unlike the big stuff, carbs, proteins, and fats, our bodies mostly can't manufacture these things. We have to be really deliberate about getting them.
Right. We depend on external sources, food, supplements, and sometimes sunlight to keep these systems running. But here's the key way to sort them out: fat-soluble and water-soluble.
Let's start with the long-term tenants, the fat-soluble group, A, D, E, and K. What's the biggest difference between how they're handled?
Think of them as VIPs that need an escort. They're absorbed along with the dietary fat, often with the help of bile salts. Because they dissolve into fat, they get stored in fatty tissues and the liver. The stability is useful because we don't need to replenish them daily. But the drawback is that if you take too much, they accumulate and can become toxic.
Oh, so that's why you can't just chug a massive bottle of vitamin A without consequence. Okay, so if those are the long-term tenants, what about the water-soluble ones, the vitamin Bs and Cs?
They're the polite visitors. They dissolve in water, circulate freely, and the excess is eliminated through urine. They don't hang around, and because we don't store them well, we have to consume them regularly.
Speaking of the water-soluble ones, which two do you think deserve the most attention up front, just based on how closely they work together?
Definitely vitamin B9, which is folate, and vitamin B12, cobalamin. They're a classic pair because they work hand in hand in DNA synthesis and red blood cell formation. When either is deficient, you get that specific type of failure, megaloblastic anemia. Not only that, remember how they're water-soluble vitamins, which naturally means they shouldn't be able to be stored for long durations? However, this pair is an exception because they can be stored in the liver.
And don't forget about vitamin C. We'll dive deep into that later, but it's the scaffolding crew. It holds together your collagen, which is the most abundant protein in your body. Without vitamin C, your entire structural framework collapses.
So, to anchor the big picture, fat-soluble vitamins are like stored resources with long-lasting effects and a risk of overload, while water-soluble vitamins are like active team members that need constant replenishment.
Perfect. With that foundation, let's begin our journey. And it makes sense to start with vitamin A because without it, you literally can't see anything at all. Welcome aboard, everyone. As we begin our educational flight, let's talk about our first major nutrient, vitamin A. I consider this one of the multi-system control panels of the group.
It's complicated because it's not just one thing. It's a whole family of related compounds called retinoids. The key players are retinol, retinal, and retinoic acid. And if you know anything about skincare, there's a high chance you've already heard of them. And don't forget beta-carotene, which is the plant-derived precursor that converts into vitamin A in the body.
So they sound similar, but their jobs are distinct. Can you tell us what's the difference between retinol, retinal, and retinoic acid?
Okay, so starting with retinol, it's the alcohol form. That's how it's often stored and transported. When retinol gets oxidized, it gives us retinal, the aldehyde form, which is the one crucial for vision. And if retinol is oxidized, it gives us retinoic acid, which functions almost like a hormone, regulating gene expression and cell differentiation. This really takes me back to my organic chemistry lessons in high school.
True. The chain of alcohol to aldehyde to carboxylic acid. It's like they have 3 different IDs depending on the job. But you mentioned vision. That's what it's famous for, right?
Absolutely. So, inside the retina of your eye, you have cones and rods. The cones help you see color and are essential for seeing during the day, while the rod cells help you see in dim light. If I were to tell you that vitamin A deficiency leads to something called night blindness, which cells in the retina do you think are affected?
The rods, since they help you see in dim light.
Exactly. The rod cells rely on a pigment called rhodopsin, and rhodopsin cannot function without retinol, which, if you remember, is the aldehyde form of vitamin A.
Oh, so that's why if you run out of vitamin A, night blindness is one of the earliest signs of deficiency.
Yes, and patients say they see normally during the day, but when the lights dim, if they're driving at night, their vision falters because those rod cells cannot regenerate the rhodopsin pigment fast enough.
Okay, but students often overlook its second huge job, which is keeping our surfaces healthy.
You're right. This is a game changer for understanding deficiency. Vitamin A is essential for epithelial cell differentiation. Basically, it helps the cells lining your eyes, respiratory tract, and GI tract mature correctly.
So when vitamin A is low, what happens to those surfaces? Do they dry out?
They do. They start keratinizing. They become dry, thickened, and lose their protective mucous barrier. This explains xerophthalmia, the severe dryness of the eye that can progress to scarring. And once that damage is done, the vision loss is irreversible.
Wow, and that epithelial breakdown means your first line of defense is gone, right?
Exactly. The respiratory tract becomes more vulnerable to infection, and the GI tract loses its protective mucus layer. This means vitamin A deficiency compromises immunity. It's actually a major global health concern.
Wait, seriously? I knew it was important, but how big of an impact does it really have on the immune system?
It impairs the immune function at a foundational level, especially in children. That's why kids with a vitamin A deficiency experience increased severity of infections like measles and diarrhea. That's also why vitamin A supplementation is a part of public health protocols in many regions. It's life-saving.
Speaking of foundational roles, vitamin A has another essential overlooked role: growth.
That's right. It supports normal bone growth and remodeling in children. It's not just about calcium and vitamin D.
And it even plays a part in reproduction, specifically for men.
Absolutely. Vitamin A is required for spermatogenesis, so deficiency can impair male fertility. It really is the multisystem control panel you called it earlier.
So now that we know all the incredible things it does, from vision to immunity to fertility, where do we actually get this multi-talented vitamin?
So you get the preformed vitamin A, like retinol, from animal sources like the liver, egg yolk, and butter. But you also get the precursor, beta-carotene, from colorful plants that are usually orange like
Carrots and sweet potatoes.
Yes. In fact, beta-carotene is an orange pigment that was named after the vegetable it was extracted from, carrots. But it can also be found in dark leafy greens like kale and spinach.
That is cool. Correct me if I'm wrong, but I heard that beta carotene from plants is much safer than taking it as a supplement.
You're absolutely correct. Because your body is smart, the conversion of beta carotene slows down when your body already has enough vitamin A, so you won't be overdosing on carrots.
But you can overdose on the perform stuff, which is a major risk because it's fat-soluble. What are the signs of toxicity?
So, symptoms of hypervitaminosis A include dry skin, hair loss, headaches, irritability, and most importantly, liver dysfunction. Since it's stored in the liver, when it becomes too much, it damages the liver, leading to the dysfunction.
I see, and I don't know if this is relevant, but there's a medication used to treat severe acne that I heard is similar to vitamin A. Isotretinoin? Does taking this medication have any effect on our health?
Yes, you reminded me about this point. So isotretinoin, like Roaccutane, is derived from vitamin A. And there's a toxicity effect I completely forgot to mention, teratogenicity. In women of childbearing age, the most concerning side effect of vitamin A and its derivatives, like isotretinoin, is teratogenicity, which can cause severe birth defects.
Oh, so that's why drugs like isotretinoin are so strictly monitored. I've seen that label on the box. They are chemical retinoids, so they'd carry the same teratogenicity risk.
Absolutely. And there are no exceptions. It is strictly contraindicated in pregnancy, and women who are taking the medication must be on reliable contraception.
Beautiful, that wraps up vitamin A. Our flight time so far has been smooth, and we're about to fly into the B complex airspace. Ladies and gentlemen, as we continue cruising at a comfortable altitude, our flight time through the B complex vitamins will be a little bit longer. This is the busiest stretch of airspace. Shaimaa, why are all the B's grouped together? Are they like cousins?
That's a great question, but the answer is a big no. They're not variations of the same molecule at all. They're completely different compounds, each serving a specialized metabolic function. Their common theme is that they act as coenzymes, helpers that allow enzymes to carry out critical reactions in energy metabolism, DNA synthesis, and neurological function.
Got it. So they're all mission critical support staff, but each with a unique specialty. Let's start with the first officer of the flight deck, B1, thiamine.
Thiamine's job is foundational. It allows your body to extract energy from carbohydrates. Without it, glucose, your primary fuel, simply cannot be fully broken. The active form is thiamine pyrophosphate, or TPP for short.
And TPP is like the master key, right? Which enzymes does it unlock?
Oh, there are 4 major ones, so get ready.
We're bracing for impact.
TPP is the required cofactor for pyruvate dehydrogenase. This is the critical enzyme that converts pyruvate into acetyl-CoA, which is the gateway molecule into the TCA cycle. And then we have alpha-ketoglutarate dehydrogenase. This is essential for the TCA cycle itself. And then we have branched-chain keto acid dehydrogenase. This helps break down amino acids like leucine and valine. And the high-yield favorite, transketolase, an enzyme in the HMP shunt or pentose phosphate pathway that helps generate NADPH and ribose sugars.
So if glucose is being metabolized, TPP is involved. Without it, tissues with high metabolic demand, especially the brain and heart, are the first to suffer.
Exactly. If you cannot break down glucose efficiently, you deplete ADP, and those cells fail dramatically. That's why thiamine deficiency presents so suddenly.
I imagine that malnutrition can lead to thiamine deficiency, but what's the number one cause of thiamine deficiency in developed countries?
You're right. Malnutrition, especially in populations relying heavily on unenriched white rice, may lead to thiamine deficiency. But to answer your question, the number one cause in developed countries would be chronic alcoholism. Alcohol physically interferes with thiamine absorption in the small intestine.
I see. And since we're talking about these high demand tissues failing like the brain and heart, what are the big clinical outcomes people need to watch out for when thiamine is deficient?
That brings us directly to the classic deficiency syndromes, beriberi and Wernicke-Korsakoff syndrome. Beriberi is broken into 2 main forms, dry beriberi, which is mainly neurological, causing peripheral neuropathy and weakness, while wet beriberi affects the cardiovascular system, leading to high output heart failure. And then you have Wernicke's encephalopathy, which affects the central nervous system, leading to the classic triad of confusion, ophthalmoplegia, which is paralysis of the eye muscles, and ataxia, which is unsteady walking.
What about the Korsakoff part of Wernicke-Korsakoff?
Yes, so Wernicke encephalopathy is the early part of the disease. If caught early, it can be reversed if you give thiamine. However, if it's not treated, the patient will now develop Korsakoff syndrome, which is irreversible and has other symptoms like profound memory impairment and confabulation, where the patients fabricate false or distorted memories without actually intending to deceive people.
That makes it so clear why early intervention is key. And that brings us to the absolute crucial clinical rule. If you suspect Wernicke-Korsakoff, you must give thiamine before giving glucose. If you give the glucose first, you can actually worsen or precipitate the neurological collapse.
Exactly. So, to explain why that happens, giving glucose speeds up those metabolic pathways that require TPP. If the patient has none, you suddenly increase the energy demand on the already struggling neurons, essentially starving them of their last bit of energy and accelerating the catastrophic failure.
One last teaching point, measuring transketolase activity in the RBCs can help diagnose thiamine deficiency. When you give thiamine, transketolase activity rises, confirming the deficiency. Okay, now moving on from thiamine, let's talk about vitamin B2, riboflavin.
So, riboflavin forms FAD and FMN, another pair of essential electron carriers. If you remember that FAD and FMN participate in oxidation reduction reactions, accepting and donating electrons, you've captured the core concept. Every time a dehydrogenase enzyme works, especially those in the TCA cycle and electron transport chain, riboflavin-derived cofactors are there. They're everywhere energy is being generated.
And what does deficiency look like here?
It's not usually life-threatening, but it has very characteristic physical findings, especially around the mouth and eyes. So we have angular chiliosis, which is painful fissures at the corners of the mouth, and glossitis, a smooth magenta tongue, and corneal vascularization. These tissues divide rapidly and rely on constant regeneration. So when FAD and FMN levels drop, they suffer early.
Next up, the big one, vitamin B3, niacin. Doesn't this one make two of the most essential cofactors?
It makes NAD and NADP. NAD is for ATP production, breaking things down, while NADPH is for biosynthesis, building things up, like fatty acids. It's the essential fuel for almost everything.
And what's the crazy deal about niacin? Can't it be synthesized from another amino acid?
Yes, tryptophan, but here's the biochemical loop. That conversion itself requires vitamin B6. So if your B6 is low or your tryptophan intake is poor, you're definitely at risk for niacin deficiency.
And deficiency of B3 leads to the classic triad everyone memorizes, right? Pellagra. What are the 3Ds?
So the 3Ds are dermatitis, diarrhea, and dementia. The dermatitis is classic. It affects the sun-exposed areas. And since NAD is needed everywhere, the GI tract and brain malfunction quickly.
What about niacin toxicity?
That's a good question, because high-dose niacin is sometimes used to treat high cholesterol. And this high-dose niacin can cause facial flushing, which is hot and red skin, due to prostaglandin-mediated vasodilation.
Let's quickly mention B5. This one forms coenzyme A, the molecule that basically allows acetyl groups to enter all metabolic pathways.
Exactly. CoA is involved in fatty acid synthesis and breakdown, and the TCA cycle too. Deficiency is super rare, but if it does occur, you see non-specific symptoms like fatigue, numbness, and muscle cramps.
Let's talk about B6, pyridoxine. Where does this one fit into the puzzle? I heard it's central to amino acid metabolism.
It is. If an enzyme transfers an amino group, B6 is likely involved. Pyridoxine is converted into pyridoxal phosphate, or PLP for short, which acts as a cofactor for tons of reactions, like transamination and decarboxylation reactions.
And since those reactions are so vital, I assume they include synthesizing our brain chemicals?
Exactly. Without B6, you cannot synthesize crucial neurotransmitters like serotonin, dopamine, norepinephrine, or GABA. That's why deficiency can cause irritability, confusion, and even seizures.
And I remember vitamin B6 is also needed for making something else really important, heme for our red blood cells.
Right. It's required for the formation of aminolevulinic acid, or ALA for short, and that's a critical step in making heme. Without it, iron can't be incorporated properly, so iron accumulates in your red blood cell precursors, and you end up with sideroblastic anemia. That connects the neurological and hematological issues nicely. Now I have a clinical puzzle for you, Sarah. Say you have a patient being treated for tuberculosis, and a few weeks into treatment, they develop seizures that don't seem to be responding to standard anti-seizure medications. What's the first vitamin-related deficiency that should flash in your mind?
So they're not responding to anti-seizure medications. That sounds like a classic high-yield scenario. If they're on TB medication, specifically isoniazid, they're having neurological trouble. I'd immediately suspect a functional vitamin B6 deficiency.
Exactly right. So isoniazid, the drug used for TB, structurally resembles B6 and can bind to the active B6 form, which is PLP, to form inactive complexes.
So the drug basically acts like a molecular thief, stealing the B6 right out of the system?
Pretty much. This leads to a severe functional B6 deficiency. And remember, we just said that B6 is necessary for making GABA, which is your main inhibitory neurotransmitter. If you lose GABA, you lose the brakes in your brain, and the resulting seizures are often unresponsive to standard medication.
That makes it clear. So the clinical takeaway is crucial. TB patients on isoniazid must be supplemented with pyridoxine to prevent neuropathy and those difficult to treat seizures. What about B7, biotin?
Biotin is required for carboxylation reactions, meaning enzymes that add carbon dioxide, like pyruvate carboxylase in gluconeogenesis, acetyl-CoA carboxylase in fatty acid synthesis, and propionyl-CoA carboxylase in amino acid metabolism. Deficiency is rare because gut bacteria produce it.
Unless
Someone eats tons of raw egg whites. Raw egg whites contain something called avidin, which binds biotin and prevents its absorption. This can lead to skin changes, hair loss, and neurological symptoms.
Oh, so that explains why biotin is so popular in hair, nail, and supplements. Because the deficiency shows up in those areas. People taking it hoping to boost their growth and strength.
Precisely. It's one of those micronutrients where the deficiency signs perfectly explain the popular marketing use.
Let's talk about the famous duo, vitamin B9 and B12, starting with B9, folate, which is essential for DNA synthesis. So a deficiency in this will hit rapidly dividing cells the hardest.
Correct. It leads to megaloblastic anemia. The bone marrow precursors like the RBCs can't divide properly, so they become large, immature cells.
And it's incredibly important during pregnancy, right?
Absolutely critical. Inadequate folate increases the risk of neural tube defects, like spina bifida. That's why women of childbearing age are advised to supplement, even before they know they're pregnant.
Speaking of causes, we've mentioned alcohol before. Does it interfere with folate too?
Significantly. Alcohol interferes with folate absorption and impairs its storage in the liver. This actually highlights a critical clinical pattern. Alcohol misuse can cause multiple B vitamin deficiencies. We already talked about thiamine B1 deficiency being common, and now folate, which is B9 deficiency, is also a major reason alcohol misuse often leads to macrocytic anemia.
And finally, B12 cobalamin. This one has two major jobs: DNA synthesis and maintenance of the myelin sheath.
And that's the key distinction. When B12 is deficient, you get the megaloblastic anemia plus neurological dysfunction. So numbness, tingling, gait instability.
So B12 and B9 work together in DNA. But I heard that a lack of B12 can actually cause a functional lack of B9, even if you have plenty of folate. Is that true?
Yes, that's a brilliant point. So B12 is needed to free B9 from its inactive storage form. If B12 is missing, the folate gets stuck in what we call a folate trap. This means that even though you might have enough physical folate, you can't use it for DNA synthesis, leading to a functional B9 deficiency.
That makes the two even more inseparable. Since B12 is almost exclusively found in animal products, what lifestyle or medical issues causes deficiency?
Well, first off, a strict vegan diet is a major risk factor since B12, as you correctly mentioned, is found almost entirely in animal products. Secondly, the absorption pathway is the key. B12 requires intrinsic factor, which is secreted by the parietal cells in the stomach.
So if anything messes up those parietal cells, you're in trouble.
Exactly. Conditions like autoimmune gastritis or surgeries like gastric bypass, which either destroy the cells or remove that part of the stomach, means less intrinsic factor is available. Less intrinsic factor means no B12 absorption, making both of these conditions major risk factors.
That makes it clear that vitamin B12 deficiency is a serious systemic problem that needs swift, accurate diagnosis. And that leads us directly into the most critical clinical distinction in hematology. Folate can correct the anemia of B12 deficiency, but not the neurological symptoms.
That's true. So if you treat B12 deficiency with folate alone, you mask the diagnosis. So the anemia improves while the neurological damage secretly worsens. That's why clinicians must always check both.
That makes sense. It's so much to keep track of. All those numbers, B1 through 12. But hold on, what happened to B4? Did we miss that one?
That's an awesome question. And here's a quick exam tip. If you ever see vitamin B4 as an answer choice, ignore it.
Seriously? It just doesn't exist?
It does not. So historically, nutrition naming conventions were a bit messy. So some numbers were assigned to compounds that weren't true vitamins or were found to be non-essential. So those numbers like B4, B10, and B11 were retired. So stick to the ones we mentioned.
That's a great tip for anyone taking a test. Perfect. And that concludes our B complex segment. Our cabin crew would like to inform you that we are gradually descending towards our next destination, vitamin C.
Please ensure all biochemical concepts are secured in the overhead compartment before we proceed.
Ladies and gentlemen, we've arrived at one of the most famous vitamins, vitamin C. Everyone knows it was historically associated with sailors and citrus fruit, but the real story behind it is much deeper and more biochemical.
It is. Vitamin C is also known as ascorbic acid. People often think of it as that vitamin for immunity, but its most fundamental role, the one that explains nearly every clinical symptom of its deficiency, which is called scurvy, is its function in collagen synthesis.
Right, collagen is the steel framework keeping your entire body structurally intact. Your skin, blood vessels, gums, bones, it's everywhere. If that's the framework, vitamin C must be the glue that welds the beams together.
That's the perfect analogy. To make strong collagen, specific amino acids, like proline and lysine, must undergo a process called hydroxylation. Vitamin C is the essential cofactor for those hydroxylation reactions.
So, if vitamin C is missing, those steps fail. That means the crucial hydrogen bonds don't form properly, and the collagen triple helix becomes weak and unstable.
Exactly. The defective collagen is the root cause. Once you see that connection, every symptom of scurvy suddenly becomes logical instead of random.
That makes sense, but before we get to the symptoms, I know vitamin C does two other major things. One involves keeping things from being damaged, right?
Yes, it acts as a potent antioxidant. It protects molecules like LDL from oxidation.
And why is LDL oxidation such a bad thing?
Because oxidized LDL is a key trigger for the formation of plaques in your arteries. By protecting LDL, vitamin C plays a role in keeping your vascular system healthier.
I see, and it specifically helps with iron absorption, which is a big deal in preventing anemia.
It does. It keeps non-heme iron, which is iron from plants, in the reduced form, that is Fe2+. And Fe2+ is much more readily absorbed in the intestines, so it's an unsung hero for increasing iron uptake.
Dietarily, vitamin C is found primarily in fresh fruits and vegetables, citrus fruits, bell peppers, strawberries, tomatoes, and broccoli.
And that's what saved the sailors. British ships famously carried limes aboard to prevent scurvy, which is how the sailors earned the friendly nickname limeys.
That's an interesting historical lesson, but it also teaches us something about food preparation today. The reasons limes worked so well is because unstable vitamin C was not heated.
That's the key practical point. Vitamin C is heat labile, meaning prolonged cooking or boiling destroys it. You can't just cook a vitamin C source down to oblivion and expect it to work.
So if it's unstable, it means you can easily become deficient, even in modern times. What are common causes of vitamin C deficiency we see today?
The primary issue is poor dietary intake, especially with severely restricted diets. For example, the tea and toast diet, which is a clinical term for a severely restricted, low-quality diet, contains virtually no vitamin C because the food is heated or processed.
Wow, so it's a failure of dietary diversity thanks to processed food. What are the other major contributors of this deficiency?
So, besides poor diet, we see it with alcoholism, as you would have guessed, and smoking. Smoking in particular increases oxidative stress and depletes vitamin C, significantly increasing a person's daily requirement.
Okay, so the body runs out of vitamin C. Since we know the foundation is defective collagen, how does physical breakdown manifest as scurvy? What are the classical signs?
It's actually a systemic catastrophe because collagen is everywhere. The first thing you see is bleeding and fragility. Fragile capillaries causing easy bruising, perifollicular hemorrhages, which is bleeding around the hair follicles, and the classic swollen bleeding gums with loose teeth.
And because collagen is also needed for repair, you'd see things like poor wound healing and general fatigue. Is it the same in kids?
It's much more dramatic. In infants, it's called infantile scurvy. They become highly irritable and they might refuse to move their legs, which is called pseudoparalysis, because they have bone tenderness due to bleeding under the bone's surface. Their rapidly developing bones suffer much more quickly.
That makes it clear how urgent the deficiency is. Since vitamin C is water-soluble, you'd think that there's no risk of excess. Have all the oranges and limes you want. But what's the danger of taking massive supplemental doses?
Well, it can lead to uncomfortable gastrointestinal issues like diarrhea, And more seriously, it can increase the risk of calcium oxalate kidney stones because vitamin C is metabolized into oxalate.
Oh, and there's a specific caution for people with iron disorders, right?
Yes, in individuals with iron overload disorders, such as hemochromatosis, excess vitamin C may dangerously increase iron absorption, potentially worsening their condition.
So, to summarize, vitamin C is essential for collagen welding, and deficiency leads to a structural breakdown and bleeding. Our flight path continues forward to the endocrine system, vitamin D.
Passengers, please keep the window shades open. We are adjusting our altitude and preparing to enter the vitamin D regulating zone.
Ladies and gentlemen, as we climb into higher conceptual altitude, our next destination is vitamin D, a nutrient that behaves so much like a hormone, it should get its own honorary flight rank into the endocrine system. This segment will be a mid-flight long-haul stretch, so settle in comfortably.
Vitamin D is fascinating because, unlike most vitamins, your body can actually make it, but only with the help of sunlight. Not just any sunlight, specifically ultraviolet B radiation. When ultraviolet B hits the skin, it converts a precursor molecule into cholecalciferol, or vitamin D3.
Right, dietary sources like fatty fish, fortified milk, and egg yolks contribute a small amount, but human physiology heavily relies on that sunlight-driven production. Here's the crucial part. The D3 made in your skin or absorbed in your diet is completely inactive.
Exactly. Think of it like a two-stop connecting flight before it reaches its active destination. The molecule must undergo 2 hydroxylation steps before becoming active.
So, step 1 happens in the liver, where D3 is converted into 25-hydroxyvitamin D, or calciferol. This circulating form is actually what clinicians use to measure vitamin D status, right? Because it reflects the total body stores?
That's exactly right. Then comes step 2, the key activation step in the kidney's proximal tubules. Here, the 25-hydroxyvitamin D is converted to 1,25-dihydroxyvitamin D, or calcitriol. This is the fully active form, and this step is tightly regulated by parathyroid hormone, PTH for short, serum calcium, and phosphate levels.
So the final active form, calcitriol, acts very much like a hormone, traveling through the body and binding to receptors to alter gene expression. What is the primary mission in the body?
Its primary job is to maintain calcium and phosphate homeostasis, ensuring you have enough of these minerals for everything from bone mineralization to nerve conduction and muscle contraction.
Let's break down its major actions for the listeners. Where does it work?
It works primarily in 3 places. In the intestines, it has its most powerful effect, drastically increasing the absorption of both calcium and phosphate. In the kidney, it reduces the urinary loss of calcium. And together with PTH, it stimulates the release of calcium from bone when blood levels drop too low.
So vitamin D ensures that there is enough calcium in the bloodstream, either by increasing absorption, decreasing loss, or mobilizing stores. But if vitamin D levels fall, the body panics and PTH rises, trying to desperately keep up with calcium.
And that's where the crash happens. When PTH rises and vitamin D deficiency continues, the bone can't mineralize properly. The bone matrix is there, but the minerals can't settle, leading to the classic deficiency syndromes.
Let's teach the underlying causes clearly, because these are highly testable. It sounds like anything that reduces sun exposure or absorption increases risk.
Exactly. We have a lot of major contributors. So, firstly, reduced sun exposure due to limited outdoor time, specific clothing, or darker skin, which naturally has more melanin that reduces synthesis. And then we have dietary issues like breastfeeding without supplementation or using non-fortified milk. Obesity can also cause it because vitamin D gets sequestered and locked away in fatty tissue. And malabsorption syndromes like Crohn's disease.
So you mentioned the activation steps are in the liver and kidney. So what if these organs aren't working?
That's a huge issue. Liver or kidney disease directly impairs those activation steps, meaning even if you get enough sunlight, you can't produce the active calcitriol. Every one of these factors either decreases synthesis, decreases absorption, or blocks activation. This is why patients with chronic kidney disease often require active vitamin D analogs, bypassing the kidney step entirely.
Now let's move to the clinical consequences, which depend on whether the patient is still growing. What does deficiency look like in a child?
In children, vitamin D deficiency causes rickets. The bone matrix forms, but it fails to mineralize, leaving the bone soft and pliable. Because children are still developing, this manifests in characteristic skeletal deformities.
That includes the visible signs like bowing of the legs, the ricketic rosary, which is a widening of the costochondral junctions, and delayed closure of the fontanelles.
Precisely. Their bones can't hold their shape against gravity, so they bend. The growth plates also become widened and irregular because mineralization is impaired.
Adults, however, don't get rickets because their growth plates are already fused.
Yeah, that's right. In adults, deficiency presents as osteomalacia. Here, bone resorption and formation continue, but mineralization is inadequate. This results in bone pain, fractures from minimal trauma, and generalized skeletal weakness.
Since vitamin D is fat-soluble, excessive intake, especially from supplements, leads to toxicity. What is the biggest concern?
So, the toxicity centers around hypercalcemia, too much calcium in the blood. When calcitriol levels become too high, the intestine absorbs too much calcium, and the kidneys reabsorb too much as well, causing serum calcium levels to rise dangerously.
What does that look like in a patient?
Symptoms of hypercalcemia include nausea, vomiting, constipation, abdominal pain, and confusion. And in severe cases, calcium deposits in soft tissues, such as the kidneys or blood vessels, causing nephrocalcinosis or vascular calcification.
Wow, so from sun exposure to bone health to kidney stones, vitamin D truly earns its honorary membership in the endocrine system.
It does. It's a deceptively simple molecule that behaves like a hormone with far-reaching systemic effects.
We are now preparing to depart the endocrine airspace and re-enter the antioxidant defense zone. Our next destination, vitamin E.
Passengers, please remain seated and fasten your seatbelts. We're about to encounter a patch of free radical turbulence.
Welcome to the antioxidant defense zone. Shaimaa, give us your simple memory tool for vitamin E, chemically known as tocopherol.
Tocopherol, because it protects against free radicals. It's actually a family of compounds, but alpha tocopherol is the one with the highest biological activity in humans.
That mnemonic is gold. The entire physiological purpose of vitamin E can be summarized as preventing free radical-mediated lipid damage.
Let's explain why that's so important. Cell membranes are made of lipids, specifically polyunsaturated fatty acids, which are incredibly vulnerable to oxidative stress. Free radicals attack these lipids, starting a chain reaction called lipid peroxidation. Once it starts, it spreads rapidly, destroying the membrane.
So vitamin E isn't floating around somewhere random. It's physically embedded in cell membranes, right at the front lines, acting as a built-in antioxidant shield.
Exactly. It intercepts those free radicals before they can damage the lipids and stops the chain reaction from continuing.
And which cells rely most heavily on this defense?
Red blood cells in particular. They carry oxygen, which naturally encourages oxidative reactions, and their membranes are rich in those polyunsaturated fats. Without adequate vitamin E, the membranes weaken, the cells rupture prematurely, and you get hemolytic anemia.
And this is especially relevant in premature infants, who often have low vitamin E stores and can develop hemolysis unless supplemented.
Beyond hemolysis, deficiency also causes neurological problems. Because the nervous system relies heavily on intact lipid membranes, especially in myelin, chronic oxidative damage can affect nerves.
So patients may develop ataxia, reduced reflexes, and loss of proprioception, which means patients lose their sense of where their body parts are in space.
And since vitamin E is fat-soluble, its deficiency is closely tied to fat malabsorption. We see it in conditions like cystic fibrosis or cholestatic liver disease or disorders affecting lipoprotein formation, where there is decreased fat absorption.
A quick practical point. Vitamin E is abundant in vegetable oils, nuts, seeds, and leafy green vegetables. And it's actually the least toxic of the fat-soluble vitamins, which makes sense because its role is protective rather than regulatory. But here's the catch. High supplementation, especially synthetic forms, can interfere with another fat-soluble vitamin, vitamin K.
Exactly. Excessive vitamin E can antagonize vitamin K-dependent clotting pathways, increasing the risk of bleeding, particularly if a person is already on anticoagulants.
Let's reinforce your mnemonic one more time. Tocopherol, free radical protection.
And when vitamin E is gone, free radicals run wild, damaging red blood cells and nerve membranes.
That wraps up vitamin E. We'll pause briefly as we approach the coagulation airspace, where vitamin K is found. Ladies and gentlemen, as we begin our approach towards the final destination of today's flight, we enter the coagulation airspace, home of vitamin K. If vitamin E was our antioxidant patrol, vitamin K is our chief officer of clot formation and calcium placement.
That's the perfect title. The most high-yield idea to anchor here is simple. K is for clotting. The entire coagulation cascade cannot function properly without it.
And the reason why is elegant chemistry. Vitamin K acts as a cofactor for an enzyme that performs GABA carboxylation on specific clotting factors. What does that modification actually do, though?
It's like turning on their power switch. Without that modification, those factors cannot bind calcium, and without binding calcium, they can't attach to phospholipid surfaces, meaning they remain inactive.
So the liver can produce the proteins, but without vitamin K, they are like untrained crew members, present but totally useless for the job. Which factors are we talking about, though?
The crucial ones are factor 2, which is prothrombin, factor 7, factor 9, and factor 10. I like to remember that as 2 plus 7 equals 9, and the 10 is just an add-on. And don't forget proteins C and S, which are natural anticoagulants that also depend on vitamin K.
So where do we get this vitamin? I know it's a bit unique among the fat-soluble ones.
It is. Vitamin K1, or phyloquinone, comes from leafy green vegetables, but vitamin K2, or minaquinone, is produced by our intestinal bacteria. This means the body doesn't rely solely on diet. About half of our needs come from our gut microbes.
Wow, but since vitamin K is fat-soluble, its absorption still requires fat, making it sensitive to malabsorption disorders like cholestasis or Crohn's disease.
Exactly. And because the gut microbiome produces a significant portion of K2, broad-spectrum antibiotics can wipe out that bacterial factory and create a deficiency, even if the diet hasn't changed. That's why patients on prolonged antibiotics sometimes develop unexplained bleeding tendencies.
That's one classic exam scenario. What's the other crucial one involving newborns?
Newborns are incredibly vulnerable. Their intestines are sterile at birth, so they have no gut bacteria. And the placenta does not transfer vitamin K well, and breast milk contains very little. This combination puts them at a serious risk for vitamin K deficiency bleeding. That is exactly why every newborn receives a vitamin K injection. It's life-saving.
Let's talk about its other big role, bone health. How does vitamin K influence calcium?
It's basically the traffic controller directing calcium to its correct place. Vitamin K activates a protein called osteocalcin, which helps incorporate calcium into the bone matrix. Without it, bone mineralization suffers.
And it activates another critical protein, matrix GLA protein, MGP.
Yes, MGP is essential because it prevents inappropriate calcification of soft tissues, especially blood vessels. So a deficiency can paradoxically lead to calcification where you don't want it and weak bone where you do.
So if clotting factors are inactive, what does vitamin K deficiency look like in the clinic?
It's all about bleeding, easy bruising, prolonged bleeding, gum or mucosal hemorrhage, and a prolonged prothrombin time, or PT, on lab tests.
And PT increases first because factor 7, which is vitamin K dependent, has the shortest half-life and drops earliest. We should also note that the liver synthesizes these factors, so severe liver dysfunction can limit factor production even with adequate vitamin K.
Finally, a quick note on toxicity. It is rare from food sources, but synthetic virgins at very high doses may cause hemolytic anemia or jaundice, particularly in infants.
And with that, we conclude our exploration of vitamin K, the guardian of clotting and the director of calcium placement. Our vitamin flight has now passed through all major stations and we're preparing for landing.
Please return your tray tables to their upright positions as we prepare a final high-yield recap of everything covered in today's journey.
Ladies and gentlemen, we are beginning our final descent. Before we touch down, let's run through a quick but powerful recap, a final systems check of everything we covered today.
Let's start with vitamin A, our visual systems officer and epithelial architect. Remember the key forms retinol, retinal, and retinoic acid. Retinol is the light switch for night vision, so deficiency starts with night blindness, then progresses to irreversible corneal damage or xerophthalmia. And beware of excess, especially teratogenicity from preformed vitamin A.
Then we enter the busiest airspace, the B-complex vitamins, each one performing a distinct metabolic job. B1, thiamine, is the key to carbohydrate energy, powering pyruvate dehydrogenase and transketolase. Deficiency leads to beriberi and Wernicke-Korsakoff syndrome, particularly in alcoholism.
And don't forget the rest of the crew. Deficiency of B3 or niacin gives us pellagra, which is the combination of 3Ds, dermatitis, diarrhea, and dementia. B6 or pyridoxine is vital for neurotransmitters and heme, so deficiency causes neurological issues and sideroblastic anemia, often triggered by isoniazid. And B9, which is folate, and B12, cobalamin, are important for DNA synthesis.
And the big distinction, B12 supports myelin, so its deficiency causes neurological deficits, plus megaloblastic anemia. Remember to treat the deficiency with B12 first, because folate alone masks the anemia but leaves the nerve damage untreated, a notable clinical distinction.
After that, we cruised into vitamin C, the collagen maintenance engineer. Vitamin C stabilizes collagen's triple helix. Deficiency manifests as structural failures, fragile blood vessels causing perifollicular hemorrhages, bleeding gums, and poor wound healing.
Then we ascend to the endocrine layer with vitamin D. It starts with sunlight, and activation happens in the liver and kidney, producing calcitriol, which raises serum calcium. Deficiency leads to rickets in children and osteomalacia in adults. Excess causes dangerous hypercalcemia and soft tissue calcification.
Next came vitamin E, our membrane-bound antioxidant, or tocopherol. It protects against free radicals. Deficiency causes hemolytic anemia due to red blood cell damage, and too much vitamin E antagonizes vitamin K, increasing the bleeding risk.
And finally, vitamin K, the chief of clotting factors and calcium placement. Remember K for clotting. It's required for the gamma carboxylation of factors 2, 7, 9, and 10. Deficiency leads to bleeding, which is why newborns require supplementation.
When you lay all of these vitamins side by side, a clear pattern emerges. Each one performs a job the body cannot do on its own. The deficiencies don't create random symptoms, they create predictable failures in exactly the pathways those vitamins support.
It's just like our aircraft. Lose a tiny but essential bolt of vitamin, and slowly, quietly, systems unravel. Understanding that helps you predict the disease instead of memorizing it. As we prepare to land, please ensure all your knowledge is safely secured. On behalf of your PodBites crew, thank you for joining us on this journey through the world of vitamins.
Our estimated arrival time is now. The weather at your destination looks excellent, with clear skies thanks to healthy vitamin A levels, strong bones supported by vitamin D, and no turbulence from free radicals thanks to vitamin E.
We hope this episode clarified a topic that can feel overwhelming and help transform vitamins from a form of memorization into a logical, integrated system.
Please gather all your personal belongings, including a stronger understanding of water-soluble versus fat-soluble vitamins, deficiency patterns, metabolic roles, and clinical clues.
This concludes today's episode of PodBites. Thank you for flying with us, and we look forward to having you on board again soon. Let's go! Let's take flight out of here!
No more flying.